Oh, thank you for the introduction, and I loved that talk. We're a few minutes ahead of schedule, which is good for me, because we get invited to give talks at meetings, and sometimes there's stuff you have to look up a lot of things and spend a lot of time learning, and some things are you're super passionate about, and some things you are not. That's just the way it is. This talk it encompasses like my whole heart, my whole passion about this specialty. I am a Foregut fellowship trained person because my fellowship was actually called Thoracic Foregut, but it was the only one I could find in the country at the time. And now that we have Fellowship Council wrapping their hands around and giving the resources, things will be markedly improved for patients and us. 7 seconds, I do some work with Medtronic. It doesn't have anything to do with this. I wish they had more to do with fellowships. They could give us more money. We could pay for a lot of things, but this does not directly affect my talk at all. Okay, we're gonna start with this. It has been well published over and over again that if you have a patient with dysplasia, dysplastic Barrett's segment, you can treat it endoscopically and you can cure it about 87% of the time. That's been published over and over again. This paper shows same data, that you've got dysplasia, treated it with endotherapy, there's about 14% that remains. We've shown that if you add an anti-reflux procedure to those patients and then continue their treatment, you can push that cure rate to 98%. We know this. This was published in 2015. It's a small series, but either way, there's other papers that show similar things. This is on the current, as of yesterday, American Cancer Society page, and it shows an 80% mortality for esophageal cancer. How is this possible? I mean, this doesn't even make sense to me. Okay, this is another set of data for Foregut. This is a recent survey just published a couple years ago, I guess now. It all seems like the same time, doesn't it, for all of us? Anyway, showing that about 110 million people in the country have weekly GERD symptoms, which by some definitions would be GERD, not just symptoms. And half of the patients, a little more than half of patients who take daily PPIs are considered refractory, so they're still struggling. That's 20 million people. 20 million people that should be seeing a Foregut specialist to discuss why the medications aren't working, what if they're misdiagnosed, who knows what's wrong with these people? I don't know because we don't see them. 25,000 anti-reflux procedures annually. That's not even a fraction of this 20 million. So when you look at Foregut Fellowship, some people say, Foregut Fellowship, there's not enough cases to go around because there's only 25,000. Yeah, there's only 25,000. I have 20 million people that need to be seen. So there is plenty of work to do. Work is not the problem. Now, I am really fortunate to have two of my dive buddies. These are my two friends that we dive together, and they are key opinion leaders in gastroenterology. On the left is Stu Speckler, and on the right is Mike Smith. So we sit and talk. We talk over drinks, we talk in between cases about this stuff. And this is what they tell me. A thoughtful and tailored surgical approach can offer the best treatment, but a poorly done Nissen can be worse than the disease, Christy. Okay, fine. And then they say, what our society, what our people, the gastroenterologists who feed us cases, this is what they're telling each other. Oh, these surgeries are rife with side effects. The cure is worse than the disease. All the patients are back on meds anyway. It's just a temporary fix. They all break down. It only works well in high volume centers and nobody has access to that. This is what's going on. So this is so frustrating. We got all these patients need care. The gatekeepers think we suck. I mean, frankly, this is what happens. You have a gastroenterologist out there who has surgical referral hesitancy. They finally are forced to do it on some patient, some one out of a year, they finally get one to their local general surgeon who is qualified by general surgery standards to do a Nissen, and they get a terrible outcome. And so the cycle continues over and over and over again. We need a better army. We are responsible for this. So I like to look at sort of lots of things in medicine, but Foregut, when I think about this, I think there's a complex disease, there's education problems, and then there's business and healthcare delivery. And they all kind of overlap as we move forward in trying to fix this problem. So 50 years ago, our Foregut founders did big open surgery. And they also started they really pushed esophageal physiology testing. And at that time, it was just beginning. There weren't volumes of books to read. There was not. They created those books. And over time, as we all know, we have mountains of data to read, right? We have HRM. We're not looking at these tracings anymore. We're talking about Chicago classifications and the latest update and all the things. We are not doing as much open surgery sometimes, but mostly we're doing all these complicated things that they did with little tiny instruments through holes or through flexible endoscopy. We're begging for some AI and some help. I mean, way different, way different. And this is just a spattering of the complexity that we are all dealing with today with Foregut surgery. It's awesome, it's fabulous, and it can totally encompass an entire career and certainly an entire training program. This is my mentor, Tom DeMeester. And when it was like the first couple weeks of fellowship, and I think I transfused a patient without telling him. He was so mad at me. He was so mad at me. And I thought, I'm qualified to understand when someone needs a blood transfusion. I just finished 6 years of training, And he said, yeah, I understand. I respect you, Christy, that you're board eligible general surgeon, but I am here to refine you. And I was so offended. I was so offended. Like, what have I been doing for the past 6 years? What exactly? You're so arrogant. This is the most arrogant thing anyone could say. But over the years, I have actually realized that he was right. And he wasn't trying to be arrogant. It's that he was trying to build on my basic fundamentals of general surgery and teach me how to become a Foregut surgeon. I think that my attitude that I had at that time is fundamental to this cycle. My attitude was, what the hell? I know what I'm doing. I'm a board eligible general surgeon. I trained for 6 years. You can't say that to me. And so that's what most people feel when they leave general surgery. The board tells them they can go out and do a Nissen. The board tells them they can do an esophagectomy. Nobody else tells them otherwise. And that's what this is from. You don't know what you don't know. All right, so general surgery. I'm not going to go into that because it's a subject for the next talk, but general surgery takes a lot of time. There's a lot of ground to cover to teach us about patient care, healthcare delivery, professionalism, fundamental technical skills, of which there are not just open surgery, it's all this other technology too, anatomy, physiology, just taking care of patients. And surgical fellowships, not just Foregut, but all of them, they are advanced specialty studies. Leaders in Foregut need to work with general surgery educators to help delineate what constitutes the baseline of Foregut surgery education. And then the fellowships needs to take it to the next level. General surgeons that are, there's gonna be the generalist, especially in smaller towns. They need to have some Foregut skills, no doubt. But they don't need to know how to do a Heller, to be honest. They need to do a good Barrett's exam. They need to do, we need to figure this out. I don't have the answers, but we need to be collaborative with this. So now we're gonna switch gears a little bit for business and healthcare delivery. And I'll tell you, this is data, this is from conversations that I've had with multiple business healthcare experts. So their perspective is this: quality, affordability, volume. That's what they tell me. Okay, volume, it makes sense, right? We all know volume, well, they must be thinking more revenue for the system. And that's true, but they recognize, maybe even better than we do, that more volume is more efficient care and that it's better outcomes. And how they measure it is patients go home. Cases are clipping along, they're quicker, they get more volume into their ORs, and the patients go home. That's what they see, and that's how they measure it. And so they're looking at this. Now, what do the plans see? What else? They see that GI cancer is projected at the top one of their top 3 problems that they're looking at. The disease burdens of GI problems, obesity, GI in general, and cancer is huge for them. They're paying attention. They want to get ahead of it. They want to reduce the comorbidities that are leading to these problems so that their patient population, their base that pays their bills, is lower. They want to reduce the resultant cancer because cancers are super expensive for the plans. And all of this will lower costs. They want to save lives. Now, about 10 years ago, these executives started thinking about GI. And they would go to the people that control the money. And the people that controlled the money, they understood like cardiac issues. They understood stroke and heart attack and how to make things more efficient and run the systems and do all this stuff. They didn't really understand GI. So it was slow. It was slow. And those people started coming to our meetings. And if you notice, they're lurking around. They're listening. And finally, over the past probably 5 years, there have been digestive health institutes popping up all over the place. And those health plans, those hospitals, those people are looking for specialists. They're looking for GI specialists: colorectal, liver disease, obesity, cancer, and foregut. They are asking us, how do we find you? How do we find foregut-trained people? And we don't have an answer, because Lena was absolutely a Foregut fellow, but she doesn't have the tag because her Foregut fellowship wasn't called Foregut fellowship. So we need to work on this, make sure we get the right people running these digestive health institutes, and we can collaborate. Okay, so why start a Foregut fellowship, which is the title of this talk actually? To define Foregut as a specialty, to improve Foregut training, to standardize education, to develop quality metrics, be accountable to payers and patients, make it easy to identify Foregut specialists. And ultimately, we will deliver the highest quality of care, which is what we want, right? But why should you do it? Why should you do it? Because you should, the time is now. It's a beautiful thing. You can improve your own skills and education because these major societies are collaborating to provide you with this education. You will be able to join us with the mission of providing good Foregut care. And for the first time ever, miraculously, we're coming up with a Foregut curriculum and standards of care. And we have a lot of work to do. We need a lot of help. We need to build a better army, right? But really, it's this, okay? The real reason to start the Foregut Fellowship is this. We need to do better, period. But as an aside, it's also super fun. Foregut Fellows are the best. And that's about it. Thank you very much.